I'm a hematologist at Meridian Valley Medical Center in Spokane, Washington, or at least I was, until I submitted my resignation 5 weeks ago. You can call me Dr. Alexander Hartwell if you want, though most people in the blood disorders unit just called me the transfusion specialist. During my 24 years there, I've seen everything you can imagine in hematology: severe iron deficiency anemia that nearly killed young mothers, aggressive leukemias that turned children's blood into poison, rare clotting disorders that caused massive strokes in healthy adults, hemophilia cases where a simple cut could lead to death, and every kind of transfusion reaction the human body can produce. Allergic reactions that covered patients in hives, fever spikes that reached 106 degrees, hemolytic reactions that destroyed red blood cells faster than we could replace them, and immune responses so severe they required immediate steroids and life support. But what I'm about to tell you about are 3 cases involving blood transfusions that made me question everything I thought I knew about human blood compatibility, and ultimately led me to leave the profession entirely. Let me be clear about something from the start. In 24 years of practicing hematology, I have never been a doctor who believes in medical mysteries or unexplained phenomena. I've always been rigorously scientific in my approach, skeptical of unusual claims, and confident that every medical event has a rational, discoverable cause. I've debunked supposed miracle cures, explained away apparent anomalies with proper testing, and consistently found logical explanations for cases that initially seemed impossible. My colleagues at Meridian Valley knew me as the doctor who would spend weeks researching obscure blood disorders, run dozens of additional tests, and dig through medical literature until I found a scientific explanation for even the most puzzling hematological presentations. Meridian Valley Medical Center is a 847-bed academic medical center serving eastern Washington, northern Idaho, and parts of western Montana. It's the primary teaching hospital for Washington State University's medical school and home to one of the most advanced blood banks and transfusion services in the Pacific Northwest. Our blood disorders unit handles over 22,000 units of blood products annually, from routine red blood cell transfusions to rare factor concentrates for bleeding disorders. We maintain one of the largest inventories of rare blood types west of the Mississippi River, including several units of Rh null blood, often called golden blood because it's compatible with anyone who has rare blood types within the Rh system. During my nearly 2.5 decades at Meridian Valley, I supervised more than 8,000 individual blood transfusions, consulted on hundreds of rare blood compatibility cases, and managed situations where patients' lives depended entirely on finding blood that their immune systems wouldn't reject. I've worked with patients who had developed antibodies to so many blood antigens that finding compatible donors required searching national registries. I've handled emergency trauma cases where patients lost 80% of their blood volume and needed massive transfusion protocols involving dozens of units. I've managed hemophiliacs who required weekly factor infusions, sickle cell patients who needed monthly exchange transfusions, and cancer patients whose chemotherapy had destroyed their bone marrow's ability to produce healthy blood cells. In hematology, we operate under strict scientific principles that have been refined and tested over more than a century of medical practice. Blood typing, cross-matching, and compatibility testing are precise sciences with established protocols that have saved millions of lives since Karl Landsteiner discovered ABO blood groups in 1901. The major blood group systems ABO, Rh, Kell, Duffy, Kidd, and dozens of others follow predictable genetic patterns that we understand down to the molecular level. Each red blood cell carries specific proteins on its surface called antigens, and each person's immune system produces antibodies that will attack foreign antigens. When you give someone blood with antigens their immune system doesn't recognize, the reaction is swift, severe, and well documented in thousands of medical studies. The compatibility testing process we use at Meridian Valley follows protocols established by the American Association of Blood Banks and the Food and Drug Administration. Every unit of donated blood is typed for ABO and RH status. Before any transfusion, we perform a type and cross-match, mixing the patient's serum with donor red blood cells to detect any incompatibility. We test for irregular antibodies that might cause delayed reactions. We verify blood types with multiple samples and different testing methods. The entire process is designed with multiple safeguards to prevent transfusion reactions, and in properly matched blood, integration with the patient's circulatory system should be seamless and life-saving. When transfusion reactions do occur, they follow well-established patterns that we can predict, treat, and prevent. Acute hemolytic reactions happen within minutes when incompatible blood causes massive destruction of red blood cells. Febrile non-hemolytic reactions cause fever and chills but aren't life-threatening. Allergic reactions can range from mild hives to severe anaphylaxis. Transfusion-related acute lung injury causes sudden respiratory failure. Each type of reaction has specific symptoms, treatment protocols, and prevention strategies that are taught in every medical school and hematology residency program in the world. The 3 cases I'm about to share with you violated every one of these established principles. These weren't simply rare adverse reactions or unusual antibody responses that required looking up obscure blood group systems. These weren't cases of human error, contaminated blood products, or equipment malfunction. These were events that defied the fundamental laws of immunology, hematology, and cellular biology. Events that challenged not just unusual aspects of blood compatibility, but the basic scientific understanding of how human blood functions at the molecular level. What made these cases particularly disturbing to me as a scientist wasn't just their medical impossibility, but the fact that each one was exhaustively documented, investigated, and verified by multiple independent sources. When unusual transfusion reactions occur, hospitals are required to report them to the FDA, conduct thorough investigations, and document every aspect of the case for medical review boards and safety organizations. Each of my 3 cases underwent this level of scrutiny and more. The first case began on what should have been a routine Thursday evening in March 2019, when I received a consultation call for a 34-year-old woman named Isabella Rose Creek, who had been involved in a severe automobile accident on Interstate 90 just west of Spokane. Isabella had suffered massive internal bleeding from a ruptured spleen and liver lacerations, and the trauma team estimated she had lost nearly 40% of her blood volume by the time the paramedics got her to our emergency department. She was going into hypovolemic shock, her blood pressure was dropping dangerously low, and she needed immediate blood replacement to survive. Isabella's blood type was B positive, which is relatively common, and we had plenty of compatible units in our blood bank. The trauma team had already sent samples to our laboratory for type and cross-match, and our blood bank technologists had identified 6 units of B-positive red blood cells that were fully compatible with Isabella's blood. The cross-match tests showed no evidence of irregular antibodies or unusual reactions. Everything appeared completely routine from a transfusion medicine standpoint. The first unit of blood was started while Isabella was still in the trauma bay, before she was taken to the operating room for emergency surgery to repair her internal injuries. The blood appeared to transfuse normally, no immediate reaction, no change in her vital signs, no signs of incompatibility. Within 30 minutes, her blood pressure began to stabilize and her oxygen levels improved, exactly what we would expect from successful blood replacement in a trauma patient. Isabella underwent 4 hours of surgery, during which she received a total of 4 additional units of red blood cells, 2 units of fresh frozen plasma to help with clotting, and 1 unit of platelets. All of the blood products were carefully cross-matched and appeared to be perfectly compatible with her blood. The surgery went well, her bleeding was controlled, and by early Friday morning, she was stable in our intensive care unit with what the surgical team considered an excellent prognosis for full recovery. But on Friday afternoon, approximately 18 hours after her first transfusion, Isabella developed symptoms that none of us could initially explain. She began experiencing severe joint pain in her knees, shoulders, and wrists. Her temperature spiked to 103.2 degrees Fahrenheit. Most concerning examining her hemoglobin level, which should have been stabilized by the 5 units of red blood cells she had received, began dropping rapidly. In the span of 6 hours, her hemoglobin fell from 10.8 grams per deciliter to 6.2 grams per deciliter, as if her body was destroying the transfused blood cells at an accelerated rate. I was called to evaluate Isabella late Friday evening. As her condition continued to deteriorate, my initial assumption was that she was experiencing a delayed hemolytic transfusion reaction, a condition where the patient's immune system slowly destroys transfused red blood cells over the course of days rather than minutes. This can happen when patients have low levels of antibodies that don't show up on initial compatibility testing but become activated after exposure to foreign blood antigens. However, when I examined Isabella's blood samples under the microscope, I found something that didn't match any delayed transfusion reaction I had ever seen or read about in the medical literature. Instead of the typical signs of hemolysis, fragmented red blood cells, increased bilirubin, or cellular debris, Isabella's blood showed something far more unusual. The transfused red blood cells appeared to be intact and functioning normally, but they seemed to be changing in ways that our laboratory equipment couldn't properly measure or categorize. When we analyzed Isabella's blood using flow cytometry, a technique that allows us to examine individual cells and their surface proteins, we found that the transfused B-positive red blood cells were still present and undamaged, but they were displaying antigen patterns that didn't match either her original B-positive blood type or the B-positive blood she had received. It was as if the donor cells were gradually transforming to express surface proteins that shouldn't exist in human blood. Our senior laboratory director, Dr. Margaret Thorne, who had been working in blood banking for over 30 years, told me she had never seen anything like the cellular changes we were observing in Isabella's blood samples. We sent samples to 3 different reference laboratories, including the American Red Cross National Testing Laboratory in Philadelphia, to verify our findings and rule out equipment malfunction or technical error. All 3 laboratories confirmed our results and reported that they couldn't classify Isabella's post-transfusion blood according to any known blood group system. Meanwhile, Isabella's clinical condition continued to worsen in ways that didn't correspond to any recognized transfusion complication. Her joint pain intensified to the point where she required continuous morphine infusion. Her fever remained persistently high, despite broad-spectrum antibiotics and anti-inflammatory medications. Most alarming, she began experiencing episodes where her heart rate would spike to over 180 beats per minute for no apparent medical reason, followed by periods of profound weakness where she could barely speak or move. By Monday morning, 5 days after her initial transfusion, Isabella had developed what appeared to be an autoimmune response, unlike anything documented in hematology literature. Her immune system seemed to be attacking not just the transfused blood cells, but her own native blood cells as well. Blood tests showed elevated levels of multiple antibodies directed against her own tissues, including antibodies against her kidneys, liver, and nervous system. Dr. Patricia Kenwood, our chief of immunology, was brought in to consult on Isabella's case. After reviewing all of her laboratory results and clinical findings, Dr. Kenwood told me, "Alex, in 22 years of practicing immunology, I've never seen an autoimmune response that developed this rapidly or involved this many organ systems simultaneously. It's as if the transfused blood triggered her immune system to forget the difference between self and foreign tissue." What made Isabella's case even more puzzling was that the transfused blood had been donated by 5 different people, all thoroughly screened and tested according to standard protocols. The donors were contacted and tested again to ensure they hadn't been carrying any infectious agents or unusual antibodies that might have been missed in the original screening. All of the donors were healthy, their blood showed no abnormalities, and none of them had ever been associated with transfusion complications in other recipients. We tried every treatment protocol available for severe transfusion reactions and autoimmune crises: high-dose steroids to suppress Isabella's immune response, plasmapheresis to remove the antibodies from her bloodstream, immunosuppressive medications typically used for organ transplant rejection. Nothing seemed to slow down or reverse the process that was destroying her blood and attacking her organs. The most disturbing aspect of Isabella's case wasn't just the severity of her condition, but the way her blood continued to change in the laboratory even after it was drawn from her body. Blood samples samples that tested normal when first collected would show the same unusual antigen patterns within hours of being stored in our laboratory refrigerators. It was as if whatever was happening to Isabella's blood was continuing to happen even outside of her body, in controlled laboratory conditions where cellular changes shouldn't occur. This phenomenon violated basic principles of cellular biology that I had learned in medical school and relied on throughout my career. Human red blood cells are essentially simple, membrane-bound sacs filled with hemoglobin. They have no nucleus, no DNA, no ability to produce new proteins or change their surface characteristics after they've been released from the bone marrow. Once a red blood cell is mature, its antigen profile should remain completely stable until the cell is destroyed and removed from circulation. Yet Isabella's blood cells were somehow continuing to modify their surface proteins in ways that our laboratory equipment could detect but couldn't explain. Dr. Thorne suggested that we might be witnessing some kind of post-transfusion genetic recombination, but that would require DNA and cellular machinery that mature red blood cells simply don't possess. Other theories proposed by consulting specialists included prion-like proteins that could alter blood cell membranes, viral infections that hadn't been detected by standard screening tests, or autoimmune processes that were modifying antigen expression in real time. None of these theories could adequately explain all of Isabella's clinical and laboratory findings, and none of them led to effective treatments that could halt the progression of her condition. As her second week in the hospital began, it became clear that Isabella was dying from complications that modern medicine couldn't understand, classify, or treat effectively. Her story, and the 2 cases that would follow, would ultimately force me to confront the possibility that there are aspects of human blood and transfusion medicine that our current scientific understanding simply cannot account for. Aspects that challenge not just the limits of medical knowledge, but the fundamental assumptions about human physiology that form the foundation of modern hematology. Isabella Rose Creek's condition continued to deteriorate throughout her second week at Meridian Valley Medical Center in ways that defied every treatment protocol we attempted. By day 10, her autoimmune response had become so severe that her body was attacking virtually every organ system. Her kidneys began failing, requiring continuous dialysis. Her liver enzymes skyrocketed to levels typically seen in fatal poisoning cases. Most disturbing of all, her neurological function started declining rapidly, with episodes of confusion, hallucinations, and periods where she seemed completely unaware of her surroundings. What haunted me most during those final days wasn't just Isabella's suffering, but the growing realization that her blood was continuing to change in ways that violated everything I understood about human biology. Each morning, when I reviewed her laboratory results, I found new abnormalities that shouldn't have been possible. Her blood cells were displaying surface antigens that don't exist in any known human blood group system. When we tried to type her blood using standard laboratory methods, our equipment would give different results every few hours, as if her blood type was literally changing in real time. Dr. Margaret Thorne, our laboratory director, became so concerned about the unprecedented nature of Isabella's case that she contacted the Centers for Disease Control and Prevention in Atlanta. She explained that we were dealing with what appeared to be a new type of transfusion complication that might pose risks to the broader blood supply if it was somehow transmissible. Within 48 hours, a team of CDC epidemiologists and hematology specialists arrived in Spokane to investigate. The CDC team, led by Dr. James Richardson, spent 3 days reviewing Isabella's case, examining her blood samples, and interviewing everyone involved in her care. Richardson had investigated dozens of unusual transfusion reactions over his 15-year career with the CDC, including cases involving rare blood types, contaminated blood products, and previously unknown infectious agents. After completing their investigation, he told me something that still gives me chills when I remember it. Dr. Hartwell, he said, in all my years investigating transfusion medicine safety, I've never encountered a case where the fundamental molecular structure of human blood appeared to be changing after transfusion. We've run Isabella's blood samples through every test available to modern medicine, including genetic sequencing, protein analysis, and electron microscopy. What we're seeing violates basic principles of cellular biology that have been established for over a century. The CDC team's final report, which I obtained a copy of after Isabella's death, concluded that her case represented an unprecedented and currently unexplainable alteration in red blood cell antigen expression following routine blood transfusion. The report noted that all standard safety protocols had been followed, all blood products had been properly screened and tested, and no evidence of contamination, infection, or human error could be identified. The report recommended enhanced monitoring of all blood recipients for similar symptoms, but admitted that the medical community had no framework for understanding or preventing what had happened to Isabella. On her 14th day in the hospital, Isabella experienced what appeared to be a massive systemic immune reaction. Her temperature spiked to 107.3 degrees Fahrenheit, a level that typically causes permanent brain damage within minutes. Her blood pressure dropped to barely detectable levels. Her heart went into a rhythm called ventricular fibrillation, where it essentially quivers instead of pumping blood effectively. Despite immediate resuscitation efforts, including electric shock cardioversion, high-dose epinephrine, and emergency intubation, Isabella went into cardiac arrest. We worked on her for over an hour, cycling through every advanced cardiac life support protocol available. At one point, we briefly got her heart beating again, but her neurological responses indicated that she had suffered severe brain damage from oxygen deprivation. Her family, who had been maintaining a constant vigil at her bedside since the accident, made the agonizing decision to discontinue life support after consulting with our ethics committee and pastoral care team. Isabella Rose Creek died at 3:47 a.m. on April 2, 2019, exactly 19 days after what should have been a routine blood transfusion following her car accident. The official cause of death, listed on her death certificate, was multi-organ system failure secondary to severe autoimmune reaction of unknown etiology. But that clinical language couldn't capture the reality of what we had witnessed. Is a previously healthy young woman, whose immune system had been triggered by transfused blood to attack her own body in ways that medical science couldn't explain or stop. What made Isabella's death even more tragic was that her original injuries from the car accident had healed completely. The surgical repairs to her spleen and liver had been successful. She should have made a full recovery and returned to her job as an elementary school teacher in Coeur d'Alene, Idaho. Instead, she died from complications related to the blood transfusion that was supposed to save her life. The autopsy results, performed by Dr. Susan Kellerman, the chief medical examiner for Spokane County, revealed findings that were as puzzling as Isabella's clinical course had been. Dr. Kellerman found evidence of widespread autoimmune damage throughout Isabella's organs, but the pattern of tissue destruction didn't match any known autoimmune disease. Most significantly, the autopsy showed that Isabella's bone marrow had been producing blood cells with abnormal antigen patterns right up until her death, suggesting that whatever had triggered the changes in her transfused blood had somehow affected her body's ability to produce normal blood cells. In 18 years as a forensic pathologist, Dr. Kellerman told me after completing the autopsy, "I've never seen an autoimmune process that affected so many organ systems simultaneously while leaving such unusual cellular changes in the bone marrow. It's as if something fundamentally altered her body's blueprint for making blood." Perhaps the most unsettling aspect of Isabella's autopsy was what happened to her blood samples after her death. Dr. Kellerman routinely collects blood and tissue samples during autopsies for toxicology testing and microscopic examination. These samples are typically stable for weeks or months when properly preserved, but Isabella's blood samples continued to show the same unexplainable changes even after her death, as if whatever process had affected her during life was continuing to alter her cellular material post-mortem. This phenomenon led Dr. Kellerman to take the unprecedented step of consulting with the FBI's Laboratory Services Division, which handles cases involving unexplained deaths that might involve unknown toxins or biological agents. The FBI laboratory confirmed that Isabella's blood showed molecular changes that couldn't be explained by any known chemical, biological, or infectious agent. They classified her case as unexplained biological phenomena and recommended that any similar cases be immediately reported to federal health authorities. In the months following Isabella's death, I found myself obsessively reviewing every aspect of her case, searching for some detail I might have missed that could explain what had happened to her. I consulted with hematology experts at major medical centers across the country, including specialists at Johns Hopkins, the Mayo Clinic, and the National Institutes of Health. Every expert I spoke with agreed that Isabella's case was medically unprecedented and scientifically inexplicable. Dr. Robert Chen, a leading researcher in transfusion medicine at Harvard Medical School, reviewed Isabella's complete medical records at my request. After studying her case for several weeks, he told me, "Alexander, what you've documented challenges fundamental assumptions about how human blood works at the molecular level. If I hadn't seen the laboratory results and autopsy findings myself, I would have assumed this was a case of documentation error or equipment malfunction. But the evidence is too comprehensive and has been verified by too many independent sources to dismiss." The psychological impact of Isabella's case on me was profound and lasting. For the first time in my 24-year career, I had encountered a medical situation that had no explanation, no treatment, and no prevention strategy. I began questioning my confidence in transfusion medicine and wondering how many other patients might have experienced similar reactions that were misdiagnosed or attributed to other causes. I started reviewing cases from earlier in my career where patients had experienced unusual complications after blood transfusions. Were there subtle signs I had missed? Had there been other instances of unexplained autoimmune reactions that I had attributed to more common causes? The possibility that Isabella's case wasn't entirely unique, but rather the first time such a reaction had been properly documented and investigated, was deeply troubling. My sleep became increasingly disturbed by recurring nightmares about Isabella's final days. I would dream about her blood cells changing under the microscope, about laboratory equipment giving impossible results, about trying to explain to her family why modern medicine couldn't save their daughter from a routine medical procedure. I found myself avoiding transfusion consultations when possible and spending excessive amounts of time reviewing compatibility testing for even the most straightforward cases. 6 months after Isabella's death, I received a phone call that would prove that her case was not an isolated incident. Dr. Maria Santos, a hematologist at Seattle Children's Hospital, had heard about Isabella's case through medical conferences and wanted to discuss a similar patient she was currently treating. Dr. Santos described a 7-year-old boy who had received blood transfusions during surgery for a congenital heart defect and was now displaying many of the same symptoms. Isabella had experienced severe joint pain, persistent fever, rapidly changing blood antigen patterns, and an autoimmune response that wasn't responding to standard treatments. Dr. Hartwell, Dr. Santos told me during our phone conversation, "I've been practicing pediatric hematology for 12 years, and I've never seen anything like what's happening to this child. His blood is changing in ways that remind me of the case report I heard about from your hospital. I'm wondering if we're dealing with some kind of new phenomenon that affects a small percentage of transfusion recipients." The possibility that Isabella's case wasn't unique, that other patients might be experiencing similar reactions to blood transfusions, filled me with a mixture of scientific curiosity and profound dread. If this was a reproducible phenomenon, it meant that our blood supply might pose risks that we didn't understand. If it was truly rare, it meant that patients like Isabella would continue to die from medical procedures that were supposed to be safe and routine. I began corresponding with Dr. Santos and other hematologists who had heard about Isabella's case through medical networks. Slowly, a picture began to emerge of other patients who had experienced unusual complications after blood transfusions, complications that didn't fit standard categories, but shared some similarities with what had happened to Isabella. Most of these cases had been attributed to rare autoimmune reactions or unusual infections, but when viewed together, they suggested a pattern that the medical community hadn't recognized. The weight of these revelations, combined with the trauma of watching Isabella die from a condition I couldn't understand or treat, began affecting my ability to practice medicine effectively. I found myself second-guessing every transfusion decision, spending hours researching cases that should have been routine, and struggling to provide families with the confident medical guidance they needed during crisis situations. Isabella Rose Creek's case had opened a door to medical mysteries that I wasn't sure I wanted to explore further. But as I would discover over the next 2 years, her story was only the beginning of a series of cases that would ultimately convince me that there are aspects of human blood and transfusion medicine that challenge the very foundations of modern medical science. The second case, involving a 52-year-old construction worker named Thomas Brightwater, would occur just 8 months after Isabella's death, and would prove that whatever had happened to her was not an isolated incident. The third case, which I encountered only 6 months ago, would be so disturbing that it would ultimately drive me to resign from the profession I had devoted my entire adult life to mastering. These 3 cases, taken together, represent something far more significant than unusual medical complications. They represent evidence that human blood may possess properties and capabilities that our current scientific understanding cannot account for, properties that can be triggered by the act of transfusion in ways that transform life-saving medical procedures into biological nightmares that defy explanation and resist treatment. Isabella's story haunts me not just because of her tragic death, but because it forced me to confront the limitations of medical knowledge and the possibility that some aspects of human physiology remain fundamentally mysterious, even in our age of advanced scientific understanding. Her case serves as a reminder that medicine, for all its sophistication and success, still encounters phenomena that challenge our most basic assumptions about how the human body functions. The blood that was supposed to save Isabella's life instead triggered a cascade of biological changes that ultimately killed her. And despite months of investigation by some of the most skilled medical professionals in the country, we still have no explanation for why it happened, no way to predict who might be at risk, and no treatment protocol for patients who experience similar reactions. That uncertainty, that admission of medical helplessness in the face of the inexplicable, would ultimately prove too heavy a burden for me to carry as a practicing physician. Isabella Rose Creek's impossible case marked the beginning of the end of my career in transfusion medicine, though I wouldn't fully realize it until I encountered the 2 cases that would follow.